Welcome to Health Blockaders and to the Pulse Lunch. My name is Hubert Zaitchik and I run Health Blockaders together with Robin over there and Lindsay, there she is. So it's a pleasure to welcome you to our offices here in Dallas. When we don't have educational seminars and superstars presenting, we have healthcare startups here that we accelerate and invest in, 109 to date. So in case you wondered what the heck are they doing up here, this is what we do. We work with healthcare startups and invest in them pretty much before anybody else starts, taking a lot of risk. But most importantly, help them with and help hundreds of mentors. But now it's my pleasure to introduce Steve Myth. And also, for everyone to know, we have an online audience here on Zoom. So Steve, you have an X here, so they can see you. And then obviously you have everyone in the room. But for those of you who can't attend in person, thanks for joining us on Zoom today. So Steve is, of course, the President and Chief Executive Officer of PCCI, which is the Parkland Center for Clinical Innovation. Probably everyone here knows that because that's why you came, hopefully. If that's not what you were promised, then apologies. Not sure how that could have gone wrong. But and I'm not gonna really try to explain what's PCCI does because that's going to be what Steve will tell you. But what I do want to share with you is a few things about Steve. Number one, he comes at this calling with a passion to make a difference. Of course, Parkland is one of the largest non-for-profit community-focused hospitals in the country, with a leadership mandate and role to take care of those that can take care of themselves. And PCCI takes it absolutely to another level at that. Steve also serves on a variety of boards, including the DFW Hospital Council. I hope that's what that stands for, HCF, Hospital Council Foundation, Nurse Grid, and SMU Big Data Advisory Board. He's also a recipient of the Community Council of Dallas 2017 Social Innovator of the Year Award, the 2019 Dallas Business Journal Most Admired CEO Award, and there's a variety of others, including Most Innovative Healthcare Award, Most Inspiring Leader. So you're in for a treat with Steve here. He's also, which floor are you? 10. 3 floors below us, right here. So, except on the north side. So if you haven't seen his offices, also beautiful. And he has a bunch of degrees. Next to the MS, it says degrees. So is that true? More than one? MS? Also?
Unfortunately, I bleed Northwestern purple.
So Northwestern is building a whole building just with the help of Steve's tuitions, but a PhD 1 or 2 masters, undergrad economics and the master's in biomedical engineering. And then also he's an adjunct professor in biomedical engineering the last 5 years, has authored more than 100 thought leaderships and white papers and peer-reviewed publications. So, well, please help me welcome Steve Myth, and thank you, Steve, for being here.
Absolutely.
This would be your spot.
You're gonna have to keep me honest because I like to wander. So just that way I could be respectful of those online. Thanks so much for having me, for having PCCI. They'll say if you stick around long enough, you get to do a lot of fun work, and don't seek awards. They come along, they're welcome. But I've been so privileged to join the PCCI team about 7 years ago, and it's just always tell everybody it's the best job they've ever had. It brings all this, varied background that I've had, and apply all those skills in a just very meaningful way. Sue said it's help those that provide care for the most vulnerable, and drive innovation in this space. Before I jump in, a couple things. One, interrupt me with questions, slides. We don't have to go through all of them. Make this as much of a discussion as possible. Those online, if you submit it via chat, somebody's going to read them. But make this interactive. They'll be better. Hopefully for you, definitely better for me. I want to thank Dr. Parnell, to one of our board members, for showing up. That's really cool. So thank you. The other thing, it's funny, we had this conversation just before it started. AI is not new. AI has been getting a lot of publicity recently, good, bad, and ugly. But just my humble opinion is that we really are in an intersection point. AI will change the world for us, mostly better. In some cases, going to make it more difficult. And one of the things that we're focusing on, and sort of part of this bold mission, is ensuring that we use AI responsibly, we use it ethically, we use it equitably, and drive innovation in this space by building scalable solutions, but apply them. Our whole focus is towards those that serve the most vulnerable, the underserved community. That's where I feel like there's a gap, there is a need, and if we don't focus on this, those that have the means, those that have the funding, gonna accelerate way ahead of others that are doing sort of this meaningful work. And the gap between those that have it and those that don't is gonna be even bigger. So we're fortunate to have this opportunity, fortunate to have the history of experimenting with a lot of this. And some of the things that we learned throughout this journey is what I'm hoping to share with you today. And some of the, just both successes and challenges of applying this in meaningful ways, applying with a way that people can use it and makes a difference. This is not even as much about this slide of PCI, but it does encompass sort of who we are and how we do. But it's also sort of guides a little bit of the philosophy, the approach that we take this, the focus that we've taken to our work. So I figure it's important to start with this, that way you appreciate the two examples that I teed up for today. One thing that we learned early on, and we experiment in different ways, is you need a place, you need an environment, you need that digital environment to be able to do this work and to be able to take the output of this work and meaningfully send it somewhere else so people use it. At the beginning, we actually licensed this from somebody else. It worked marginally, but the work that we do is unique. So several years ago, we actually ended up building our own. Not that we thought that we're smarter, it's just more on need. So the digital data environment for any type of this work, particularly the need to integrate multiple sources of data. That's important because any of the predictive models, you need vast amount of information. Be able to do it at the individual level. So you actually able to link those data sources in a way, if we're going to predict it at that level, to be represented, protected. It's patient health data, so all the things that go around with it, and then have ways that stays up to speed and up to date to be able to integrate upstream or downstream with those. So digital environments, it's huge. For us, the way we think about it is to be able to predict behaviors or to be able to predict rising risk. You need to understand people beyond just their clinical need, particularly for everybody, but particularly becomes even more important for an organization like Parkland. So, we'll focus on is understanding their health-related needs and that health history. Strong belief that concurrently, you need to understand the mental health of an individual. It's not one or the other. It's not like now I'm addressing, depression. They're all part of the same journey. Understand where they live, understand the daily challenges, because those sometimes are barriers for them to be able to access proactively health. There are important components that actually contribute. And, you all know the research that, those factors, the non-medical driver factors contribute over 80% of what keeps people healthy. So it's important. And the last one, and we're having some conversation as well, the fourth leg of that stool for us, and this is newer, we're just starting to lean into this, is understanding an individual famous capacity for self-care. What and how much they can do, for instance, in which modalities they can do that. So those type of information that we believe is really important to be able to actually build models that help predict a rising risk for an individual. And then we apply those in three ways. Purpose on this, because in other areas of healthcare, there are much bigger companies, much better funded companies that do the work. but this is where we feel we can actually have an itch and make a difference. Clinical decision support, examples there, the trauma, sepsis, predicting of drug events, just deploying a model on workforce violence, which is really meaningful. I'll give you the example. I'll use the example there with the trauma model to sort of walk you through the journey. The second is population health models, predicting rising risks, so interventions can occur early in that cycle, keep people away from the emergency department or hospitalizations, not good for them, for their family, for the system. And then the third is been spending a tremendous amount of time right from day one of the organization on the non-medical drivers of health, social determinants of health, use whichever acronym you like, to be able to understand the characteristics of an individual's home environment at scale. How do we get hyper-localized but understand that at scale? So those are sort of the things that we focus on and spend time on. For today, I'll use an example on the trauma, on the first category, use an example on the work that we've done in pediatric asthma for the population health, and you'll see the sort of the information around the non-medical drivers of health, the social determinants of health actually being integrated and sprinkled throughout because we believe it's important. So let me pause. Anything else that you'd like me to touch on?
No, it's very quick into the presentation, but is a lot of your reaction to the population health management due to the fact that almost entirely the healthcare industry is for reactive healthcare, differential diagnosis and a couple of options versus proactive care? That be a way of easily summarising why you're doing this and where you are heading to?
I think it's so two things. It requires a little bit of a different intervention, and timing is a little bit different. You kind of see it as well. But yes, ultimately, if we can keep people healthy, keep people understanding what they can do, perhaps be able to key the information up for providers so intervention can occur earlier, we can solve so many things. However, our healthcare system has been built as a system of heroes. We're fantastic when something goes wrong. People come to the hospital, emergency room, we take care of them better than anybody in the world. Our incentive system is not really aligned with that way payments are. The other advantage that we have working with partner and partner-like organizations, that they get limited funds, but a pool of money to take care of a whole population. There's an inherent and explicit incentive to keep sort of move upstream and keep people healthy. People show up to the emergency department, probably the busiest in the country last year, or the hospital. Department doesn't get more money. So there is just an inherent incentive to actually do upstream, do preventative care, invest there so you can actually reduce, because you can't keep building more beds and that. So it's a little bit of that. That's why I think it also, when it comes to population health, inherently there is that example. So we don't have to justify that if I keep people out of the emergency department, that's going to reduce revenue, which is real, right? So you have to think about both the business side of things as well.
I got one observation. You touched a little bit on the, I look at the hurdles of how are you going to get this stuff out? I'm making one thing is the privacy issues with the data. Med City did a huge thing on digital investing. What are we going to do about the data? How we can provide it, all that kind of stuff. But the second hurdle I see with the FDA in terms of the validation of these models and setting the models, we're going to change the model nowadays. I think I think that's a big problem. One board is taking an organization that doesn't know, they don't even understand this stuff. Yeah, they're trying to create regulations for us.
Yeah, no, absolutely. And I'm going to touch on a couple of those. One of, again, the privilege of being sort of done this for we've been asked to join a number of different national organizations to help bring the perspective of Parkland public hospitals. I'm on the advisory board for the National Academy of Medicine, which is developing AI guidance. We're monthly calls with the White House and NIST for developing these. We're active members with the Health AI Partnership, which is Duke, Mayo, Berkeley. So we're both trying to learn from others and bring the perspective to the table for those exactly type of things. I'm going to highlight how, it's a journey. I don't think the FDA has figured it out yet. I don't think the ONC has figured out yet. I think that's it. They're willing to listen. They're willing to sort of listen to those that are doing the work. And this is going to be an evolving, moving space. And I'm going to talk about, well, actually, sort of, the first slide on kind of beyond sort of this initial discussion I wanted to talk about is the whole life cycle. If you're going to start in AI, if you don't have this mapped out, don't bother, because you can build a great model, you can license that model from somebody else, and you might be able to deploy it. And before you know, it's like, okay, well, what happens then? Once you deploy it, how do you monitor it? What's the process of making the decisions of where is that model drifting towards something that was not intended? This is even after you've determined that this is appropriate for your patient population, is predicting that you've done, when you decommission it. Yeah. So this, and think about it, if you're not just doing this with one model, because this is accelerating at the rapid pace. Now all of a sudden you have 50, you have 100, you have, multiple vendors. How do you do that, right? So, and again, this is probably something that not many think about. You're thinking about, hey, is this adequate for my organization? How much does it cost? Helping, doing this and that. Let's say that you go through all of that, and let's say that you have the capabilities internally to do that evaluation yourself, or you pay somebody else because and that's good. You should not always just take somebody's word. You need to do it yourself, because your patient population might be different, might be unique. You can't just you need to make sure after you do that, how do you sustain it? If it's part of a clinical decision making, if the model stops working, who's responsible? Is the IT teams? Is it, is it the vendor? This is complex and this is evolving. And it takes time. One of the other things that I'll show you.
One of the things that I've always seen with the model says, one fact is, model will always give you an answer. But is it good?
Is it good?
And so I don't see that they don't work. They always work. They're always going to give you an answer. The question is, how much confidence? What's the confidence level on that? That's the key thing.
Right.
This validation comes in, and whether it's the right question.
Right. Well, and I'll change it a little bit, because we've experienced this. It doesn't always work, because an input that you were expecting to come in, something changes the password upstream on the EHR because there's an upgrade to Epic, and all of a sudden the one data point out of 200 stops coming in, model stops working. Well, is the model stop working? No, the model actually not from the model. It's all this happening upstream that could actually break it. So in that case, who steps up? If this is something that's run an SLA every 15 minutes or every hour, the clinical teams, it's using it to inform their decision. Is it the IT team? Like you as sort of the AI development model, you don't have access upstream. So what's the coordination of making this work? Challenging, right? Now, not insurmountable. This I can here to say, this works today. I believe it's saving lives today. It's making a difference for clinicians and patients, but it's a journey. I'm also sort of the examples I'm giving you today. It's within the broad AI portfolio, but I would say it's augmenting intelligence, augmenting decisions. These are not meant to replace the physician, the nurse. I don't believe we're there yet, at least not for clinical application. We don't even know what good is yet to be say, hey, if we pass this threshold, the error rate is 5%. Is that good enough? We don't know that yet because we've never looked at it. It takes multiple studies. So it's augmenting the frontline staff is the entity that makes the ultimate decision. But I believe, and you see sort of at least the examples that we've had, it is a powerful new tool to be able to help with those decisions, and that's where I think the power of it is. So first example of the clinical decision support component is a model that we built, deployed at Parkland. Now in the process, actually standing this up at Grady in Atlanta, is around predicting mortality for trauma patients coming through the Parkland ED. Busiest ED in the country, there weren't tools previously, more manual, to be able to alert the improvement or deterioration of trauma 1 level or trauma 2 patients that are coming in. So the experience of managing this being based on the physician's experience. Think about, you have unconscious patient coming in. One of the critical decisions, not after you stabilize the patient, is when is the patient ready to go to surgery or to be transitioned? The surgeons want to get the patient there as soon as possible because the sooner you operate, the better the outcomes. You go too fast, the patient might not make the transition or through the operation. If we wait too long, the outcomes are not as favorable. And Dr. Starr, who is the lead orthopedic trauma surgeon in Parkland, UT Southwest, is the champion of this, one of the most renowned surgeons in the country, if not the world, said, look, you know, our decisions historically have been like this. Patient ready? Think so. Patient out? No. Literally, he described thumbs up, thumbs down. One of the other times, the teams who spend significant amount of time is this argument between the ER staff and the OR staff and the ICU staff. So like, no, they're ready, let's go. No, they're not. You gotta, you know, and think about, you don't just have one. You have multiple. Think about shifts. I mean, you know, at some point people need to go, you know, home. How do you translate that information from one shift to the other? Think about training, you know, sort of just various levels of, you know, somebody with 20, 30 years experience, somebody who's, you know, early in their residency. Think about the amount of data that's being generated real time on each of those patients. I mean, the decisions just are overwhelming. Like, I mean, just thinking about it is like, wow, you have a whole new appreciation of this. Built the model to sort of say, hey, can we actually predict the likelihood of mortality using the information, and then use this to guide those decisions, do it at scale. One of the things that you'll see throughout, this has been our experience. This is not something you do in 6 months, particularly when you have something like this, for overall, where, you know, the number of patients that die is small. So when you think about AI and data, you need to have enough sample to be able to run these models on. So there's like literally 5, 6, 7 year process of not only building it, testing it, bringing it into real practice. And now it's, you know, it's used real time. One of the other things that I think it's important to sort of, how do you actually do this well? Well, it's in that whole development cycle. This is the way sort of we've approached it. First, you know, you always have a key stakeholder, the team. Their experience, it's invaluable as you start with this information. It's not sort of just coming, well, just going to apply some data. You need to be able to understand not only what they've done, but what's been done for hundreds of years in some cases and how that's evolved. Then you're sort of curating the data and trying to find out what gaps in the data, the frequency of the data that you're using, how is it coming in, bringing all that in, and, you know, identifying missing data and inaccurate data. What do you do with those? Then you sort of finally start to build models, because you build multiple and figure out which ones, you know, you end up with. Let's say that you end up with a model that, again, in every stage of the process, you consult with the clinical teams, because they're the ones going to be able to trust and make decisions on this. You land on a model, then we'll always run that in silent mode, because you build the model on historical data. Now we say, all right, well, let's see how it performs real time, but we're not making any decisions on this. Amount of time varies. How much, you know, actually data do you have to run it in silent mode? Use the silent mode to figure out, okay, well, where are we going to display this? How is it going to be displayed? What information do you need to have? Then you start to deploy it in stages. So, okay, I'm going to start with this small group or this department. Works well, we're going to move to the next, and then finally you have final deployment. And then back to that life cycle that you need to have very prescriptive of how I'm going to analyze on an ongoing basis the performance of the model. When do I revisit to make sure that, how do you handle expansion? Because it was built for the adult population. All of a sudden say, hey, well, this is useful for 15+-year-olds, not just 18. No, you kind of have to go through the whole validation cycle all over again. So that's why it takes time if you're going to do it right, and you want it to make sure that's actually visible and believable. I'm gonna send these slides for those that are interested, not worth spending time on what variables, but those of you that are geeks like me and like that level of detail providers, let me just give you a sample of some of the variables that go into model. Again, things that are being collected nonstop throughout the process. A bit of also information about the model performance, how it's being trained, 2009-14, how it's tested, what some of those specific components of the performance of the model itself. Get probably too much detail, but I want to put this in there because are important. Part of that initial sort of valuation when you determine that's ready. Also, part of it is, as much as we want this to be an exact science, there's an art to it. And the art part about it is, again, this conversation back and forth is how do you set the thresholds? Because it's a balance between having the right alerts, having the alerts be at the right time to enable a better decision, but not having too many alerts. So the false negative, false positive, it's not sort of, well, I'm going to just optimize for one, because, it's part of that conversation, part of the discussion with the individual team that actually going to use it. So it's sort of, for this model, again, yeah.
On the previous slide, so your sensitivity and specificity, are those essentially your metrics on accuracy of the model?
These are the ones that the team has determined that with the input from the clinicians, as you optimize the different components, that these are the ones that we feel good that the model's performing according to our expectations. So yes, from a pure model performance, this is sort of what the things that, we look at across all models and sort of determine.
Often models run like 70-80% accurate, which of course is not going to work for you guys.
It depends, right? For example, it might have something different for, a pediatric asthma model. Depends what you're trying to predict, what the window is. Timing is really also important. When does the prediction occur? Do I have enough actual time to do something about it? Or if it's telling me an hour before and I need, 6, then it's predicting, but it's not.
And also get there and looking at your earlier slides, I think you're basically going for ongoing learning, where typically models you train once and you're done. Maybe you can see them drift, then maybe you come back. But
Yep.
With the level of accuracy you need, you're ongoing.
Right. No, that's exactly right. Then you kind of just put in here a little bit of the approach to the model, which kind of end up ultimately making things. Just so you got to and this one, here's also predicting this sort of critical 48-hour window is not doing anything in the first 12 hours. That's such hands-on the clinicians, they don't need a distraction. You need to have enough data that's been collected on the patient for this to actually be accurate. It's sort of, it starts to trigger at that 12 hours, starts predicting at the 11th, but using this, that's where sort of this becomes really important and useful. And that's how the clinical teams are using it. The other really important, where do you put this information? This was a ton of time that was spent on where do you put this? Because this is the, epic page that comes up on a patient. It is probably the most expensive digital real estate that you can have. So actually getting something to display on every patient on this, it's a big deal. And then where? Because here the bottom, the keeping part of traumatic mortality, sort of just be say, hey, we want to see this. And then the other part is going back to the question, great, models are amazing. So, using this, having thresholds above this, we're, with these type of decisions we make, in this range, we make different decisions. It's good. One of the things that regulatory agencies are asking for good reason, and actually, clinicians and frontline staff as well, give me the information behind the model. I can know what actions to take if you tell me what's driving that score at that particular time. It's how do you take the black box out of it? And this is not just that I trust it, but you need it, particularly if it's something that's externally developed. All right, tell me what's driving, but it's from enabling a better decision. Then I can know what to chase, what to prioritize. And that's one of the things that we've built. And we built it not only, it started with this one, now it's being rolled out for sepsis. And we're doing a way that it's equally effective, whether it's something a model we built or somebody else, is this transparency. It's hard to see in this one page, but basically it's one page, one click of a button, you see one page. I'll break down a bit. At the top, you see the current score. You see how it trended, that, that one is mainly gone up 1 point over the last hour. This is updated every hour. It dynamically pulls up the top factors that are driving the prediction for that score. This gives that collision. Okay, here's what's driving. What's more important this particular time? Dynamically pulls it up based on what's driving the prediction of the model. It gives you a longitudinal of the score itself. You can hover at any point and see again. You can look back. What was the score? What are the factors that drive it? And then it gives you the actual data for each of those points, not just the top 5, but it is. So what you're trying to do is also bring full transparency around the information, which helps drive what do I do next or what do I need to focus on if I'm going to improve the score to a level that now is going to drive a different decision making. So, whichever way you end up doing it, this transparency behind the model, it's something that it's expected moving forward, but it's something that has significant value as well. So, I think that's been one of the learnings, and it's an important feature of it. Let me pause for a second. I'm going to sort of shift to the asthma example, but let me see if there are any questions. Any questions online? Yeah.
A really great contribution here. It's like a credit score. This is the evolution of the credit score. You got this score, you get hammered.
Right.
So what did I do wrong? And then kids would ask you, well, you haven't lived long enough. It's not something you can fix. But now you see the trends, you see your 5 top factors. And when you see, not a lot of credit history, whatever, it's like, I don't know anything about that. But hey, wait a second, been late a couple of times. So, and that's
Right.
also now a demand. I mean, I want to see why that's bad, maybe to disqualify me from a good loan. And you can't turn the clock back. But I feel like that level of transparency is kind of inversely applicable to people saying, I'm not going to just take some judgment. I'm going to ask for the data, and because I'm not one person.
Right. And you want to create something that's meaningful, useful, and then you ask that person to, like, if they're trying to understand now, they have to go through 15 clicks to get to the information. How, sort of there's a need to simplify, and how do you bring that information? But that's a perfect description of like, yeah, it's like sort of my, credit score. There's hey, what do I do? Why did it go down or up? And what do I do to do it next? Yeah, Dr. Parnell. And then...
Back to your question, which is pretty interesting. And Steve won't say this as a board. They've been doing this for a while, and he's considered a thought leader around the country in relation to that. People on that White House panel, he's had been doing a lot of good work. He's being credibilized, I think that they've been doing this work for some time. Going on the parking now, doing where you maybe can.
Yeah, about a dozen years.
I think we started out in 2012, so we've been doing that for a while. He really does understand this a lot, even on that committee, so. He won't vote.
You understand this?
Go try to understand. Try to just offer practical perspective.
If you're not involved, from the beginning, obviously, the FDA would just do what the government does, is give you something, somebody else to make the decisions who don't know anything about it. Thank you.
Question then, yeah. Oh, let's go there. Just, I'm trying to order. There's no rhyme or reason behind it.
Strides, fabulous. How long before these models become prescriptive? Like, if these conditions exhibit, now we suggest you do this, this, and this. They actually prescribe.
To a certain degree, it's a bit prescriptive from that perspective, and that's at least how we get into it. The visibility behind the model itself and sort of teeing up the top factors that are driving it, to me, that is a prescriptive approach, meaning look at these 3 or 5 and do something about it if you're going to want to improve it. So to me, that transparency drives towards it. I think that you see the threshold that is being set when a different action happens. I mean, that's a prescriptive component. In this case, they set at 50%. There's no, sort of just based on the model performance of that. Little score is under 50. that patient does not move to the OR until that score gets above 50. If the score is above 50, great, green light, let's go. All those conversations that I've talked about, sort of back and forth, they don't happen anymore. Everybody's looking at the same information, same data. This is what's driving it. What's a bit both humbling and scary. We rolled this out. I forgot exactly, when it was. Went live, finally. 2 weeks into it, remember very specifically, Saturday morning, I think it was about 10 o'clock, we get a text from Dr. Starr. The text says, does the model take weekends off? No, that started a great sense of humor. Stop, sort of, we talked a little about that. Well, obviously we jumped into it. Guess what happened? One of the inputs, just not a major update in Epic, happened overnight. It changed something, and one of the information that was flowing into the model stopped flowing. So the model, stopped working. One of the other things before going live, again, depending on what decision, what is the SLA? What is sort of the response time they need to commit to? Now all of a sudden, now you're dealing with 24/7. You need to coordinate with the IT team because we couldn't fix that change in Epic, but we needed to diagnose it. We need to reach out. We need to have the partner on the IT side to say, hey, here's what problem is, go fix it. And within the hour, we're back up. Now, the lucky thing is that sort of this, that you get better at it because now it's practice like, hey, anytime that we make a change, we're going to test it before we actually implement it, including testing how we could impact this. So, but to me, humbling because it's like, wow, like somebody actually, not only they notice gone, they said like, I need this now, just tell me what it is. So, I think we need to be careful as we introduce this, even as augmenting decision, not replacing it, is becoming a key part of that portfolio. You can't let it fail. Yeah.
I'm going to narrow my question. So at the end of the day, you're only measuring the first 72 hours of trauma. So it doesn't carry over to ICU or outliers or deaths.
Correct. I think one of the other thing that's really important is to be very specific. What you're measuring, what you're predicting. Because once you expand it beyond what you've intended or built or trained the model on, you need to go through the whole process again. Again, like very tangible. One of the things was expanding the age, meant to be the adult population. Well, we couldn't just shift and all of a sudden trigger if it's 15 plus. We needed to go through the whole validation to make sure that transitioning to a different part of the organization, a different type of decisions. So it's both the model itself and the education of the teams that are using it and what triggered the decision and what decisions should be made based on the information. And we have a very different sepsis model. It's something different. Even that, for example, for sepsis, one sepsis model doesn't work. ED sepsis or present omission, people, it's a whole different ballgame, a whole different model. Inpatient sepsis, medicine, different than surgical, different than OB. So you can just have one sepsis model. Some have tried, didn't work. You need to be very specific. And as you expand, you need to kind of go through the whole cycle, good, better, or ugly. You just have to, because otherwise you could run. This is even beyond the drift of the model as it sort of continues to learn for what you intended it to be. Yeah.
Real simple question. Do you have a threshold number of patients you need to create a good model?
Absolutely, and it depends. As the smart, interns in the room who join us for the summer. Yes, no, and sometimes that's why the trauma model took so long to build. You needed to have enough data to be able to predict. I mean, predicting mortality again. Not a lot of people die, and hope they don't. So then you need to just have more time to be able to do it. Also, it's really hard to do this across multiple organizations. We talked at the beginning, the data privacy, where do you put the data? So, the approach that we've taken is you build it within one, Then if you try to do somewhere else, you need to retrain the model on that. Even if it's very similar, you still have geographical variation, other things. And that's sort of the approach. Takes longer, but it's the right thing to do. Okay, one question then, because this is a cool example too, just a little bit different.
Just quickly, the danger of the hype of AI is that it does not state what the real process is for getting to an amazing solution like this. Number one, it's people. Number two, it's the process. And then lastly, it's the technology. The question that I had for you was, were your technology partners like Epic really ready for what you wanted to get to? And were their solutions actually capable, the way that they were architected 20 years ago, really ready for more predictive versus reactive care?
I would say in some cases, yes, in some cases, no. And this is not just a cop-out answer. I truly mean it. For some organizations, yes. For some organizations, no. What I mean by that is it depends what you're trying to predict. I think for things that are more operational in nature and throughput, yes, I would say that things that get into clinical, it gets a little bit nuanced. And particularly, again, you need to make sure that what's trained and built on, it's representative as predicting the way you anticipate. Again, no show, it's a great example where a patient doesn't show up at Parkland. It's a very different reason than Highland Park, but there are others, you'll see it in pediatric asthma. So it's hard to generalize, take something that's built for, 2000 hospital, that those have segments within themselves. But look, the way I approach, if Epic has a model that works, fantastic. The organization, so it's fully integrated. You don't have to go through all this sort of rigmarole. It's easier for the IT teams to do it. Absolutely. Trying to fill in the gaps, but those don't work, or the things are a bit more complex because it requires different type of information and data to get to that accuracy of the component. All right, pediatric asthma. We have 15 minutes and we'll have a couple for questions. Start with a brief story, because this really sort of impacted me when we started working on this. Doing some presentations, I was in New York. In the audience was the New York Hospital Association, was a trauma surgeon that, at the beginning of the meeting said, hey, let me tell you all a story. So I've been doing this for a while. Trauma surgeon in the city of New York said, one day I had a patient, a 15-year-old that came in with a gunshot wound to the chest. The whole team jumped in. They didn't have the PTIM score, but they're good. Unfortunately, after everything that they tried to do, that child died. He was walking towards the waiting room to tell that mother the unfortunate news, and just head down, I don't know how surgeons, how physicians do it, but he approached the mom. She could read his posture that this was not good news, and started to say, ma'am, I'm so sorry, but your child came in with a gunshot wound and died. He was shot and died because of that. And she looked up and said, he didn't die because he got shot. No, it's like a little bit of panic. It's like, do I have the right person? Do I have the right patient? So just like, well, no, he got shot to the chest, tried to do everything he could, which he died because of that. She looked at him again, it's like, no, he didn't. And he looked puzzled, didn't know what to say. And then the mom started to say, well, he died because of asthma. It's like, what do you mean? It's like, he was a great kid. He's a good athlete. Played football. 3 years ago, diagnosed with asthma, got worse. Single mom, working too much, couldn't always afford the medication, taking here and there. His asthma got so worse that, he couldn't play football anymore. Got involved with all kinds of stuff after school in the wrong crowds. And I wasn't around to help him. And here we are today. So he didn't die today because he got shot. Got 3 years ago. because of asthma. So to me, it's sort of just, that's might be the end, but asthma, it's an extreme example, but it's a big deal. And so I'm gonna put some statistics, there are over 6 million kids affected with asthma. And it impacts different groups significantly more than other, either by race or by socioeconomic status. Huge differences. There are also just a tremendous amount of kids that show up in the emergency department because of their asthma or even get hospitalized. A lot miss school out of it. So a lot, fortunately, also die. Not because of a gunshot wound, as in that example, but they die because it's not controlled. And this is one of those things that can be controlled, can be avoided. It's avoiding the triggers with the right of medication for both the parents and the child to be able to understand the triggers and the systems, be able to follow up. Well-controlled asthma, kids do well, they thrive, they play, they learn, they grow. Poorly controlled, worst case, they die. But they miss school. Parents can't afford to take them to the emergency room because they miss, days from work, and that has all other ramifications. So it has such a multi-pronged impact on family and their kids with something that if we just know better and anticipate it, something can be done about it. So that's why sort of this was something that it's a great example where AI can make a difference. Can we predict rising risk or changes in the asthma of individuals, of kids? So action, education can happen earlier. We prevent the adverse events. So we embarked on this and sort of lots of research conversation that the goal was, can we predict 90 days out? 90 days was sort of that really good threshold. Just not too long because then people ignore it, but long enough we can actually do something about it. It has enough time to make a difference. So it's sort of this Breathe for Life, Learn for Life started. What's interesting about this is also that this program did not start with a hospital. It started with a health plan. Started with the Park Community Health Plan. Built that model, ran it for a number of years, very successful. I'll show some numbers. And then said, wait a second, health plan managing one group of patients. What about somebody like Heartland? So to rebuild the model on a different type of data. First, you have claims data only, plus the social determinants of health. Now you're working off EHR data with social determinants of health. So different. And then can this information be used to create a digitally connected community? Because it's not just one entity that's trying to help this children family. It's, in this case, in this geography, let's say it's Parkland, it's the health plan, Dallas County Health and Human Services, community-based organizations that are providing assistance or helping with for things is the schools. So it's sort of just, so how do you actually use information to identify risk and then be able to help coordinate these efforts? Yeah.
Did those doctors know that he had asthma?
I'm getting there. Great question. Great question. So build a model to identify children for control asthma, support goal to trigger avoidance, and then enhance the appropriate medication and timely administer that. That's sort of the goal. Ultimately, how do you measure this? You measure by fewer ED visits, fewer hospitalizations, can look at school absenteeism. So kids can stay in school. At the front of it is this model, right? We're not going to spend too much time. We'll show a little bit of it, but that's what triggers multiple interventions. One, direct alert, multiple threshold levels, very high, medium, low. Very high triggers a best practice alert for the physician office. So physician knows, so when they know that's asthmatic, yes, at some point that had to be a diagnosis. So this is for kids that have been diagnosed with asthma. But triggers like, look, this child's a high risk of their asthma condition getting worse. So if they show up, for whatever reason, preschool vaccination, a scrape on the knee, do something about asthma, because if we don't do something now, it's going to get worse. So a trigger alert. Monthly lists that get distributed to the primary care, the physician, pediatric offices with their patients, risk stratify for proactive outreach. Well, what if the child doesn't show up this month because there's no reason for it? How do we get ahead of it and start to do that? So engaging the physicians and the providers. Number two is engaging patients. So one of the other thing is let's create awareness for the family. So we're enrolling those families into a texting program. We've tried and done multiple apps. We played around and built a unique thing for Alexa, the Echo in home to do this. Again, different populations, different needs. For the Parkland population, texting, most effective. Retention rate 1 year, it's over 80%. With multiple reminders and alerts per week, with education, even questions about, simple questions about, is the asthma getting worse, better, that feedback into the algorithm. So educating the families about that, reminding about appointments, reminding about asthma medication, etc. And then sharing the information with others that might even interact. Again, I mentioned, prioritizing, for example, for Dallas County, health minister, they have a program to go visit, families at home. This helps prioritize which families do go visit at home based on the severity of some of those things. So sort of one simple algorithm score, just, preserve. This gives you a little bit of the texting component, which we believe and we seen to be a very effective way. That's, short, bilingual education motivation, reminders, symptom monitoring component that I think just important that makes it effective. A little bit about the sources, like who it predicts on, sort of, again, look at the time period. This has been sort of a constant journey because it started with one organization type of data, moved to another. We just were very fortunate this year to be awarded a multi-year grant from the Kaiser Foundation, the Robert Moore Foundation, for the pediatric asthma to expand this to FQACs. And that's another really important group. We're one of 5 national organizations that received one of the awards. The other one sort of wanted his own sepsis, et cetera. So, and it's then monitoring and understanding the performance of this across a variety of different settings. So, but again, it's an evolution. It takes time to make it work. A little bit more about the model. Again, it's aiming to predict the risk associated with deterioration of asthma 90 days out to avoid hospitalization, ED visit. Multiple ways to evaluate both retrospective analysis to understand how is it working. And I'll get to a couple, so we have a little bit more. Oops, went too far. Ultimately, sort of one of the reason, short of it is 36% reduction in the ED visits. One of the other things that, I don't have it here is we, monitor the satisfaction of both the providers, is they useful what they're getting, as well as the patients themselves. And to me, one of the most effective ways sort of to say, are they continuing to use it and get engaged, or do they drop off? To me, that retention component, in addition to, how satisfying, we weave those in throughout. So it's not sort of once a year and like all of a sudden you getting this big survey. It's kind of keeping it simple, which you get the components. I included some of the parameters that go into this. One of the things that we notice, again, that's why I mentioned the importance of the mental behavioral component. It's critical in this case, not necessarily the child, but the caregiver that has an impact on how well they can be controlled or not. But the last, this is some of the information about the qualitative feedback. Do they feel like they're better controlled? The high percentage. I would recommend this 92%. Has taught me how to take better care of my child asthma. So again, this is just from the texting thing that I think it's really important to understand, in this case, the parents who are the end users of this information that's triggered by this algorithm. The last word that I share is that the evolution of this, one of the other things that I want to can we make this even more broadly available to the community? Because it triggers on individual patients, right? What are the bigger community at large? So we build a pediatric asthma surveillance system that's done across the whole county. And what we've done is be able to both coordinate efforts across those multiple partners, but also put this information in the hands of individuals in the community. So if you Google asthma and DCHHS, Dallas County Health and Human Services, the first thing pops up is their asthma page on their website. If you go to that page, you will see this dashboard. You can play with it yourself. Put in your address, just like you do in sort of Google, and it zooms in your geography. It tells you the risk of asthma in that community. In this case, it's the census, either zip code or the census tract level. So, goes beyond. It also highlights the factors that are driving that, direct and indirect factors. Those that are part of the model, those that are indirect. So you can sort of see what is sort of what's driving the risk of asthma for individuals that lived in that community. Advocacy, guiding interventions, coordinating efforts, this will sort of been used. We just actually this month, it could be any day, we have a paper on this coming out in the New England Journal of Medicine Catalyst. So it's sort of just been one of those things that sort of just recognizing the value of the coordination using data. The risk, it's mimicking what we've done with that individual component. It's just bringing it at sort of a different level. So I'll end with this, and then maybe a couple questions. This is something that I feel strong about. Sort of, to me, and this is like comes from a variety of sources. One of them being a fortune cookie, piece of paper. It's like strategy without action is a daydream. Action without strategy is a nightmare. I believe that you need both to be able to be effective. But this is something that Dr. Parnell, actually, I'm glad he's here today. He told me at a baseball game several years ago, and we've done culture trumps strategy every day. I believe the culture that you're able to set within the organization, not need strategy, need execution, but that's sort of, to me, the glue. The other glue is the data, is the analysis, because AI in this case, I believe, is supercharges our ability to use data information to be transformational. And I think we just started to dabble into this. Just a couple just examples, but the opportunities ahead are significant. Whether it's the direct focus on AI or AI as a complement to another solution that you're building, it's here to stay. Just let's hope that we use it responsibly, equitably. The opportunities are there. So I'll stop. I think we have just 2 more minutes for any other questions, and just want to say it's just a huge thank you for having me.
So not to get too deep into the weeds here, but you mentioned that you try to use a commercial platform of some sort. When you say you built your own, you go all the way from scratch and on foundational, or you use like a GPT, 3.5, or a Lava or something like that. Begin with that and then build, or you go all the way down to scratch on the foundations.
So this is before GPT 3 or 4 happened. But no, not from scratch. So, we picked and we evaluated one of the 2 main platforms. We ended up, choosing the Microsoft Azure, could just as well be AWS.
You begin from there.
So begin from there and then add elements that, sort of creates flexibility and again, and be able to integrate the coding components that have flexibility, add all the different, components around the life cycle of the development and all those, but sort of just use that platform. When we deploy these, we also made a decision that this is not a central hub where you pull data out. We're deploying this within the firewalls of a organization. So their PHI data never moves out. Other complementary data like the social determinants of health, those sort of move in to complement, but their data doesn't move out. So stays within the firewalls of that system and then augmented with, again, different tools. We've built a ecosystem like this at University Health in San Antonio for their transplant database. And we took this to another level where we integrated some of the OMAP Odyssey, the Atlas sort of tools. That's sort of, so I believe it's a great, effective way to how you share what you're developing, not only sort of the models themselves, but as you're doing different studies, we identify a patient cohort population, and without the need to send data somewhere else, you share the characteristic of the definition for somebody else to replicate exactly, again, within their firewall. At least where we are now with sort of data exchange, privacy, cybersecurity concerns, it's the best that we can have to be able to do this while maintaining those integrities.
So I'm with UT Dallas, and our students do medical devices and medical mobile apps. We did 5 mobile apps for children's health that the kids could use when they left to promote their continued wellness after they left. Do you see any usefulness with what you offer, some kind of mobile app solution?
Yeah, and I think it depends on the patient population. Think, with telehealth, it's surprising how well adopted that's been across multiple age groups, that not typically considered to be tech savvy or different populations. The challenge with some of the apps for the Parkland-like population is the data plans. So, that's one of the things to consider. But I think having a portfolio of options and then meeting individuals with the options that best serves them is probably the best approach that we can take. But anything that we can do, whether it's hypertension or whether it's an engagement on this, or whether it's at home, in-home monitoring, to be able to extend how we interact and engage and empower patients beyond sort of this, it's a winning formula. You just need to think about it, sort of the cost, the adoption characteristic, the criteria, and how they can interact. Yeah, well, I don't know if it's a question or it was like, hey, and. Oh.
That is a 36% decrease in ED visits for pediatric asthma visits. Do you plan on using a similar model or text messaging programs for other chronic diseases like hypertension or diabetes, things like that, to see if there's a lot of high uninsured emergency department visits for some of these chronic diseases?
No, absolutely. So we've done and adopted this for preterm birth. That's been extremely effective. Obviously, the messaging, the frequency, all those. I think it's an effective sort of baseline way, whether it's hypertension, diabetes. I think there are emerging other solutions that can take this sort of just I'll call simple technical approach that be more targeted to be able to take this and extend it. So this is not it. This is sort of, call it the least common, baseline component, and building solutions, on top that they can be customized to different subgroups and extend that engagement. That's where I think it's a huge opportunity moving forward. You cut us off whenever you think is right. I'll keep answering questions.
Yeah. So particularly with the P10 model, can you talk about, you talked a little bit about overcoming this with pulling back the curtain, showing the inputs that go into this, but talk a little bit about adoption of this from clinical staff, the challenges that you face and how you overcome.
One, I think it's critical. They've been involved since step one, at least champions from the teams. It was, I mentioned Dr. Starr, because he was the one who's super passionate for it, but Dr. Park, who's sort of his counterpart on, the ICU OR side, involved heavily throughout. The CMIO at Parkland involved heavily throughout. So they were part of the team where at least monthly calls with them throughout this whole process. Again, they were the ones that are super passionate about. This is just, they're part of the daily life. They saw an opportunity. So they have to push the rock up the hill, this and that. Hey, this is like, hey, there's a gap here. Information on very AI. This can help with these decisions. And I think that's critical throughout, because it's also part of how do you deploy it? How do you educate? How should the nursing staff versus sort of the trauma physician, the OR staff? So that's sort of, and then, probably, I don't know if you saw it, there's a disclaimer too, just to make sure that, it's like, look, this is not meant to replace, or, your clinical decision. You're making the clinical decision. this, like augments that, provides it, I think it's built for that purpose. Now, we're not even getting into, physician out of the loop and all that. I think, we're working on some, called more Gen AI, large language model things. I think we're being careful how, where, and how we're applying those, because you have to be really thoughtful about the data sets that you're trying to train those models on. And again, sort of just that's a critical component. So using those to augment some of the historical type of AI that we've done. I won't even go into sort of the physician out of the loop, because I think that's not only a little bit too controversial, but we just don't know some of the things to even evaluate them yet. At least clinical, operationally wise, that's a whole different story. Yeah.
So you've built these tools that are saving lives, extending lives, improving the quality of the life, just like a medical device or a pharmaceutical would do, that has to go through a regulatory approval process. And you're sitting on this White House advisory panel, and the private sector seems like it's just so far ahead of the government. What are your thoughts on how the regulation of these AI type tools is going to evolve specifically healthcare?
Probably more regulated than other parts. I think certain things within the type of application as well. Again, sort of clinical decision versus, I think I'll even see a difference between PTIM and the pediatric gas. One needs to run one every hour, the other one runs once a week, right? So I think these are how do you support, how do you apply? Things that are more operational. I think that the things are going to be focusing on, are you denying care? I think some of the critical decision is patient consent. We don't know. It's like, what do you do? Do the patients need to consent? The AI is being used. Patient use of data, build and train AI models. That's a can of worms as well. Because here's sort of, AI's got a whole spectrum, not just Gen AI. So if you're going to inform a patient, or you give patient a choice, where do you draw that line? Is a BPA, best practice alert, that's been around forever, that triggers an alert, uses an algorithm to trigger the alert that analyzes data, or a machine in the room that starts to beep, again, based on an algorithm that's a statistical model. Is that infringes in AI or not? Do you need to consent the patient that, you can use a best practice alert? If they say no, we can't treat them, right? So where's this sort of threshold? Do you need to obtain consent to be able to use that data to build future models? We don't know. I think so I think it's slowly, I think the OIG is coming with guidelines, things sort of what a responsible AI, what I encourage everybody. That's a first step to comply with those and use those both in the evaluation. FDA is certainly putting forth guidelines as well. Those are going to evolve, and there's lots of discussion that guidelines came about not using age, gender, demographic characteristics in AI models. Okay, but most AI models, at least age, in some algorithms, like age is an important factor. So is it okay to use age, but it's not okay to use, something else in that list? So active discussions that, they're sort of, an opinion, and then thinking about not just moving forward, but looking back, what are those consequences that we need to sort of think about, right? Because again, there's not an easy line to say, this is AI, this is not.
So we're gonna, just this second here, we're gonna check in with you.
Well, we can do some organic conversation versus all the, so I'll stick around. We can do like a little small group. So
let's stick just time into the script here, but obviously you've printed all this thing. Steve. Thank you all for coming. So he will stick around, what if you tackle him if he's not cover all the exits. But thanks for being available for a few more minutes.
Absolutely.
All of you are of course welcome to hang around here as well. Haven't had a chance to eat lunch, there's a few still there, and there's also coffee. So thanks for joining us on a, once again, blazing hot July
Yeah.
day. So, I don't know, we have a date for our next one yet, but we'll inform you all probably being first. So thanks again for being here.
Thanks so much, Randy.
Thanks for organizing that.
Yeah.